and share screen. Can someone turn it on? All right, we're starting off with HLSD and HEP, and then David will continue probably about pharma and micro, and then we'll see if we have time for some anatomy, considering you guys sort of just rush through it. So for HLSD this week, you kind of take like a life journey like every week, and this week it's adolescence. Later on you do like adulthood, you do like middle-aged and like elderly. To be perfectly honest, these are quite low yield. I can't even remember a single question on the exam. If it was very like logical. But feel free to listen along anyway. I'll tell you if anything important, like really important comes up. So like kind of the first objective in your lecture this week was to describe the differences in development associated with puberty for like females and males. The kind of first one was that girls go through puberty first. They start around age 11 on average, whereas boys go a little bit later, starting around like maybe 14, like 13, 14. You can see that on the graph there. That first one shows height growing, which is usually corresponded with like the start-ish of puberty. Puberty is also the second time you grow sort of the most in like 1 or 2 years. So the first time is like literally as a baby, your first year of life is like your biggest growth spurt. And the second time your biggest growth spurt is in puberty. Also weight gain happens a lot. And what's interesting is that you grow a lot in height, but you grow more proportionally in weight. So that's like why if you look at the like spikes, it's like a really big spike compared to like the height is like a bit of a smaller spike. That's because like the weight distribution changes. So you have like more like an adult, I guess, body than like a child body. The sort of next learning objective was all about the developmental tasks in adolescence. And by developmental tasks, we sort of mean the physical, emotional, social like changes that you have to deal with. So like, as a kid, there are different developmental tasks to when like you're a teenager. So first is like acceptance of your new body. The second one is separation from parents, because up until 11, according to Erikson's stage of development, up until 11, you're like a really tight unit with your parents. And then later on, you start to become like an independent person. Your friends start to be a bit more than your family. Third one is develop new relationships with peers. Fourth one is find an activity you enjoy, which leads on to like finding a career you enjoy, which hopefully that is med. We'll see. The next part is talking about all about how med causes burnout, so we'll get onto that. Construct a system of values, and 5, achieve a separate identity. So this part's relevant to the extent that it refers to Erikson's 5 stages. So last week we talked about the development of theories. If you haven't seen it, check out the slides for it at least, because that's probably the more relevant aspect of the questions you'd actually be asked. Like, what's the developmental theories, rather than like specifically what challenges you have in adolescence. So like the third dot point was talking about health conditions. Pretty much causes of death as a young person are like very different to causes of death as an old person. As an old person, it's like disease and illnesses. As a young person, it's like accidental deaths. So things like genuine accidents, things like suicide, that's the more likely reason you would pass away as a young person, because your body's still working. And then other health conditions that are covered in your lecture are, and I guess issues, are binge drinking, which obviously, as you probably all know, happens quite a lot in adolescence. So it's about a third 18 to 19 years old, and around a third 20 to 29. Smoking, 2.5% of young adults smoke, but compared to 13.8 of like all adults. And this is a sort of a changing trend, because about 15 to 20 years ago, people used to smoke a lot more. So it's more of like a culture shift than like an age shift, in that now we sort of are against smoking as a culture. So it's a lot harder for young children and like adults to get into smoking. Obesity, about a quarter are overweight or obese, compared to nearly 40% in adults. And then sexual behavior, around 2/3 have engaged in some sort of sexual activity. And then down there is the breakdown kind of what happens. The important thing here is that about 60% used a condom last time they had sex, which means 40% didn't. And that's like the kind of only relevant statistic that might come up in some of your classes, but I doubt it would come up in the exam. I don't remember anything about that. So, you know, teenagers tend to get a bit of a bad rap about how their brains are developed, etc., etc. Interesting enough that our brain is kind of developed in like the areas that are responsible for rewards, pleasure seeking, the limbic system it's called, not development in like the self-control and decision-making part. So it's like we have the full capacity that we want rewards, but we don't have like the full capacity to make decisions surrounding that. So that's why they get a bad rap. But other than that, yeah, that's just kind of brain development. You study that a bit more in year 2. Obesity is a huge factor. Growing up, as we said before, a quarter apparently are overweight or obese, and that gets bigger as you progress into adulthood. The main reason is not enough exercise. So particularly, we're seeing a decrease through adolescence, and you would probably kind of notice that amongst yourselves or your peers. You used to do like so many activities in primary school, and you get to high school and do a bit less because like of academics. And you get to uni and have to like force yourself to do stuff because it's like not like part of the curriculum anymore. And particularly that affects girls a bit more than boys. All right, on to our second part, our HEP. I think this is the last or the second last HEP lecture, so exciting. The mental health enhancement stuff. This lecture was a bit annoying because we actually don't have any learning objectives properly, just have a lecture outline, which is good though, because that means they can't directly test you on it because it's not like part of the learning objectives, strictly speaking. The important thing here is to recognize that doctors traditionally have some aspects of health that are better than the general population and some aspects of health that are worse than general population. So here in green, that's like what doctors are doing better than average, and in red is what they're doing like worse than average. So smoking is a lot less for doctors, and like overweightness is a lot less for doctors too. What's a lot more is suicide, alcohol, poisoning, and mental health. And that's partly attributed to like the nature of the job and also partly attributed to access. Doctors have a lot more access to like medications than general public for like some of the poison side of things. And then down there's a table showing the different causes of death and like the general society and doctors. So as you can see, like liver cirrhosis, for instance, is quite high in doctors. And that's because doctors tend to drink more on alcohol on average. Med students, if you extrapolate down, have a bit of a similar problem. So all the things that doctors had more, med students also have more. And there are sort of two reasons. They did some research, they decided why this was. The first reason was that coming into the field, medical students tend to think it's a bit different than it actually is. So I don't know, like you think you're going to be saving lives every day, and then when you're actually a doctor or actually go to the wards, you realize that's not really the case. And the second thing is that the med side or med education side of things is that we're mainly taught to like treat illnesses like with like medications or like surgeries or like procedures. And like all of the patients coming in or like all the ICLs would be based on like the biomedical side of things. But in reality, you have people coming into the hospital all the time with like psychosocial issues. That becomes harder because of the mismatch. And then last slide for me, just about burnout and well-being. Pretty much burnout is massive, particularly in very competitive specialties. So think surgery, absolutely, and I think your roads. So your radiology, ophthalmology, anesthesiology, dermatology. Burnout is quite high in those areas at the start because like it's very competitive to get in. Mindfulness helps, gratitude journal helps, and limiting overtime helps. A note on the overtime thing, AMSA releases like a document about how to prepare for internships. The document's down there if you're curious to see how long are you expected to work, how much are you paid, etc. So generally, Aussie interns work an average of 50. So that's 10 hours, already like more than like your 40-hour work week. And that's just because you'll probably have like a lot of shift work. So you'll probably have like 6 days shift work or like 5 days of like 10 hours a day. But yeah, check out the document if you're interested in more about like internship conditions. It's sometimes a fun read to know what you're up to. But yeah, other than that, I think I am done. David, reckon? Pharmacology?
Oh, do you mind if I share screen just so I don't annoy you? Yeah, you can zone out if you want. Pharmacology. Let's go. The return of pharmacokinetics. And I use some of Peter's notes, so thank you for that. So we're gonna have to, let's go. We have to begin by reminding ourselves of some fundamental context of pharmacokinetics, which is it's essentially the way the drug is absorbed in the body, or what the body does to the drug. And you can categorize this in 4 steps. The first is the absorption of the drug, either perhaps in the small intestine, or maybe it's transdermally, or it's on the skin. Then how that drug is distributed to different areas and tissues of the body, how it's eliminated, either eliminated by the liver and then excreted by the kidneys, or eliminated through sweating or other ways, and how it's metabolized. Metabolism is often also undergone by the liver, and metabolism often makes a non-polar drug polar, so it can be excreted by the kidneys because the kidneys can only excrete polar substances. What does transdermally mean? It means on the skin. Sorry, I shouldn't have said that. It's literally not important at all. Yeah, so just remember that ADME phase in order to remember the steps in which what happens to the drug when it goes into the body. So remember, pharmacokinetics is the movement of a drug into, around, and out of the body, or what the body does to the drug. And the goal of treatment in regards to pharmacokinetics is dosing for effective response and reduced toxicities. So you want to dose amount of a drug enough to have a physiological effect, but not too much as to induce toxicities and pathology. There's 2 parameters of pharmacokinetics. One is the clearance, which is the ability of the body to eliminate the drug, and the other is the volume of distribution, or the space in the body available to contain the drug. So I was talking before about the minimum effective concentration and minimum toxic concentration. In other words, the minimum efficacy of drug concentration required to have a physiological effect. And then past a certain point, you have toxicity. And this space in between is called a therapeutic window. And this is where kind of physicians and clinicians operate within in order to reach efficacy without toxicity. This unfortunately might look familiar to you. It is showing you different routes of administrations, then how the drug is distributed in the gut, in the skin, in the muscle, brain, CSF, lung, placenta, etc. How it's metabolized in the liver, with the metabolites being excreted in the kidneys, with the final step of elimination or excretion. So these are some effects of distribution that are important to consider. So the first is, if you give a drug, will it actually go to the target tissue where you want it to go? So it will actually have the effect that you want it to have. The second is, if you do give somebody a drug, how many spaces is it going to? And as a result, what widespread adverse effects do you need to account for that may be systemic or local to areas you don't want the drug to have effects in? The more a drug distributes, the smaller the concentration in plasma. If you have a high concentration of drug in plasma and it's impermeable to the plasma membrane, so it can't go into the tissue, you're going to maintain a high concentration of the drug in the plasma, and all that drug can eventually get excreted. However, if you have a large distribution of a drug, a large volume of distribution, if it goes into various different body cavities, then you're going to have a smaller concentration in the plasma. A drug may enter cells, may enter extracellular spaces, or it may stay in the vasculature. Distribution is affected by the size of the drug. Smaller drugs diffuse across easier. Lipophilicity, a lipophilic drug will diffuse across cell membranes easier, whereas a hydrophilic drug is going to be kind of caught or trapped into particular compartments. The degree of ionization, nonpolar drugs diffuse across easier and bind into plasma tissues or plasma proteins. And plasma proteins will can saturate, or they can have fill up with drug, and then that concentration circulating in the body decreases if plasma proteins are saturated. The level of perfusion to various sites of the body refer to the supply of the drug or the distribution, and the binding is where the drug maintains or stays in the body. There's something called P-glycoproteins. This is a footnote that occasionally comes up in micro as well. These are transmembrane efflux pumps that pump drugs or sometimes microorganisms out of a cell against the concentration gradient, and this can influence plasma and tissue drug concentration, as well as bioavailability and distribution, because you're trying to get drugs to go into a tissue compartment and it's being pushed back out. These are protein pumps. Volume of distribution, this is quite an important concept. It relates to the way plasma it's a way to relate the plasma concentration to the total amount of drug in the body. So as you could imagine, it's kind of impossible to know how much drug is in various tissues of the body, because you can't just put a needle in and measure it. Like you can't know that information, how much is in the interstitial fluid. So the only access of knowledge of how much drug in the body is the amount in the plasma concentration. So we can only directly measure plasma concentration, and as a result, we assume that the amount of drug in various compartments of the body has the same concentration as the drug has in the plasma. That's what this says, and we assume the drug is equal. This is because you can make this assumption because you assume the drug is equally distributed in all compartments. These are some formulas. So the volume of distribution is equal to the total amount of drug in the body divided by the concentration of the plasma, or the dose you've given divided by the concentration of plasma, with units in volumes per kilogram of body weight or just in volume. This here is showing you the volume of distribution in various fluid compartments in the body. Sometimes in order to get, if you remember the graph I showed you, sometimes it's very hard to get to the stage. You need a lot of interfills of drugs. So sometimes to get to that therapeutic, you give a loading dose, which is a high concentration of a drug to get here, and then you'll give a maintaining dose to maintain in that therapeutic window. So you give a loading dose, which is measured in milligrams, and that's dependent on the volume of distribution of a drug times the plasma concentration. So while the volume of distribution can seem like quite an intellectual, like who cares about it, it's quite important in calculating actual clinical treatment. A high volume of distribution may be required to occupy extravascular sites and achieve target plasma concentration. So if you have a high volume of distribution, the drugs are going out of the vasculature into the tissue sites, might need to give an even higher concentration of plasma to increase the amount, higher concentration of drug to increase the amount in the plasma. The elimination is half-life is proportional to the volume of distribution as well. There's a question? Yes. When I said the concentration of plasma, I mean the concentration of drug. Yes, sorry, that's what, yeah, that means the concentration of drug in plasma. So someone asked, what does this mean? And it essentially means concentration of drug in the plasma. Might change that. I didn't think of that. Yeah, that's a good point. Sorry, so to go back, elimination is proportional to the volume of distribution. In order for a drug to be eliminated, it has to be in the bloodstream, as the kidney can only filter things that come through the bloodstream. If all the drug has moved into the tissues, it's then not going to the kidney. It can't get voided, and so you have reduced elimination if you have a higher volume of distribution, as there's less in the plasma. No worries. Elimination, so drug clearance. This is kind of a complicated concept I didn't really understand at the start. Drug clearance is a volume of plasma cleared of drug per unit time. So it's a measure is volume per time, and it's a constant relating rate of elimination to plasma concentration for a particular drug. So whereas rate of elimination is how much drug is being lost per unit time, drug clearance is how much volume is also being lost per unit time, but it's of a section of blood, how much time until all those solutes of drug in it have disappeared, have been excreted. And it's an intellectual way in order to make these formulas make sense and to make calculations. It's a hard concept, so yeah, might need to hear it a couple of times. Renal system is important. Renal means kidneys, and that's where excretion occurs. Where the glomerular, they put this in formula in, I think it's premature and they don't really test it on you. It's glomerular filtration rate, which is how much drug goes in the kidneys plus active tubular secretion, how much is put in the kidneys through another mechanism, not the primary mechanism, minus reabsorption, how much is returned to the body from the kidneys. And I think that's a lot for you to know, and I don't think they'll test you on it. It depends on urine flow rate and lipid solubility. Metabolism is primarily referring to liver clearance, a first pass metabolism, where lipid soluble drugs are made drug soluble for renal excretion. Metabolism can involve detoxifying drugs, or it can involve activating prodrugs. Sorry, just letting someone come in. So the enterohepatic recycling refers to another mechanism involved in metabolism in which bacteria deconjugate drugs to allow for absorption back into the circulation. So if you remember for metabolism in the liver, often a drug may be conjugated in order to make it polar. Polar means, as you know, hydrophilic, so it can be secreted by the kidneys. Some bacteria actually work by taking away that conjugation and returning the drug back into circulation. There are particular enzymes called CYP enzymes. These are involved in this metabolic process that detoxifies drugs or make them soluble, or sometimes even activates prodrugs, as we said before. CYP enzymes do have an ability to be saturated, and as a result, they're drug-to-drug interactions. So if you can think one particular CYP enzyme is the enzyme involved in activating a lot of drugs. So if you give two drugs that use the same CYP enzymes, those enzymes are going to saturate, and then you can have toxicity because you're going to have a really increased amount of concentration that can't be excreted. On the adverse of that, so other sorts of drugs can actually induct the efficacy of the enzyme. So giving some certain drugs can make these enzymes work really well, and they can activate other drugs really quickly. So it works both ways. You can either inhibit these CYP enzymes, which means they're unable to make the drugs polar, and so they stay in circulation, or you can induce them to be more effective, in which case they're going to reduce the concentration in the body, making them be able to be excreted. So it's your normal competitive inhibition. So now we're going to talk about elimination in a bit more detail, which I think is the core of this lecture. There's a concept called half-life, which you might have learned in school, and this is the time taken for the plasma concentration of a drug to fall by 50%, and it's in units of time. It depends both on the clearance as well as the volume of distribution. So as we said before, the clearance is a constant for a drug. So if a drug has a tendency to be cleared from the body quite quickly, the half-life is going to be quite small because it's not going to take a lot of time to fall by 50%. Similarly, if a drug is distributed all over the body, so it's not in the plasma, it can't be excreted by the kidneys, and so its half-life is going to increase because it's not getting rid of in the body. Here is a formula to remember it, 0.693 times volume of distribution divided by clearance. This does show up, so it might be helpful to learn. There's a pyramid of formulas we might have showed you last sem, and this is in that pyramid. So you use the half-life to determine the duration of action of a drug, and it tells a clinician when to give different doses of the drug, because you often dose the drug when there is the half-life. And that means the concentration of the drug will increase until it reaches steady state. And we'll go into this in more detail. Steady state is when the rate of dosing, so the rate of giving the drug to the person, is equal to the rate of elimination. So if you can think the drug is going to increase, and then at a point, the rate of dosing is going to equal the rate of elimination, and it's going to be constant, like we saw in the earlier graph here. This is at a steady state. You can see it's not moving up or down. Well, the time required to reach steady state plasma levels or eliminate the drug is 4 to 5 half-lives, always. It's always 4 to 5 half-lives. So I have some images here. The amount of time to reach steady state here, where the rate of elimination is equal to the dose rate, is when this kind of flatlines, is always approximately 4 to 5 half-lives. If you stop giving the drug completely, complete withdrawal, it's going to take about 4 to 5 half-lives for the drug to be completely eliminated from the body. And if you give an IV infusion, it's going to take about 4 to 5 half-lives for the drug to reach steady state. So that's a kind of key number, 4 to 5 half-lives. As you can imagine, as the plasma concentration increases, the rate of elimination increases as you have more drug in the body to be excreted. So more is going to be excreted because there's going to be more little particles in that solvent. This is an intravenous graph. Here we can see constant infusion. Constant infusion is also a conceptual way to think of intravenous, because in an intravenous it's constantly being infused. You can see here there's about 4 to 5 half-lives between no drug infusion to steady state. And if you've imagined that you've at steady state, you've had the IV drug infused, about 4 to 5 half-lives for that drug to be completely eliminated from the body. When you repeat dosing, the closer the dosing interval, the more it looks like constant infusion. In other words, the closer you dose together, the higher the drug is going to rise. And you want to repeat dosing at an interval of about a half-life. So when it's declined about half of what was there in the initial dose, you're going to want to repeat another dose. And that's going to slowly increase. And in about 4 to 5 half-lives, it's going to reach steady state. This is a graph illustrating the importance of dosage intervals. You can see that if you give lots of dosage intervals, the final drug concentration is going to be higher, but the amount of time it takes to reach steady state does not change. It is always about 4 to 5 half-lives to reach steady state, regardless of when you give the dose in, regardless of the frequency of the dose in. So this here is the same drug. It gets to different concentrations because so you can imagine you've given that concentration of the drug, you've had a little bit decline, you give another concentration, a little bit declines, another drug. So it's going to climb more rapidly than if you let it go, for example, after it's reached its half-life. After 50% of the drug has disappeared, if you give another dose, it's not going to climb at the same level, but they will reach steady state at the same time. That's a very hard concept and it's quite important. A loading dose, I've explained before, is when you give a high concentration at the beginning. Do I have a picture? No. It's when you give a high concentration. Loading dose is when you give a high concentration of a drug at the beginning, because you can imagine it can take a really long time for the drug to reach this therapeutic interval. So if you can't wait that long, you give a really high dosage, a loading dose, to get it up to where you need it to be, and then you give a maintaining interval to make it maintained in the therapeutic window. I always forget where I left off here. And the maintenance dose is given afterwards. The half-life determines the duration of action of a single dose. It determines the time required to reach steady state with repeated dosing, and it determines the dosing frequency. So you want to dose at the half-life to stay within the therapeutic window and avoid fluctuation. If you do it before or afterwards, you're going to have some fluctuation or some climbing. These are some formulas that are important to remember. I recommend in Sem 1, we gave you a table, a triangle of formulas to learn. To go through these formulas, the volume of distribution equals the dose given divided by the concentration of drug in the plasma, measured in liters or liters per kilogram body weight. And we've gone through all these formulas before. The rate of elimination is equal to clearance times the concentration of drug in plasma. These, if for further explanation, I've been through them. They're in the slides we've just said. This is more interesting. Maintenance dose rate is equal to the rate of elimination. And as its steady state, dose in equals dose out. So the dose rates you're giving in is equal to the rate of elimination of the drug at steady state. And therefore the formula for dose rate is equal to the formula for rate of elimination at steady state, which is clearance times concentration of drug in plasma. Loading dose is the volume of distribution times the concentration of the drug, the target concentration of drug in the plasma that you want. So this is essentially why the concept of volume distribution exists. So you know, if this amount of drug is going to perfuse from the vasculature into the tissues, it's not going to be accessible to be excreted, then I have to multiply that by the concentration of drug I want in the plasma in order to know how much dose to give at the start. We've been through this before. This is zero order kinetics. In other words, some drugs saturate metabolizing enzymes. We talked about those CYP enzymes. They can be saturated, and as a result, the rate of elimination is not driven by the plasma concentration of the drug. So if the enzyme is not saturated and you have a lot of drug, then you have a lot of enzyme conjuncting that drug, so it can be eliminated, and you're going to have an increased rate of elimination. If those enzymes are saturated, then that rate of elimination is going to be fixed depending on the enzymes. The enzymes are rate limiting, and therefore a constant amount will be eliminated per unit time, and the half-lives will change depending on the plasma concentration in zero order kinetics. Whereas in first order kinetics, when the enzymes aren't saturated, the half-lives are independent. They're based on the drug rather than the plasma concentration. As enzymes saturate as well, this is important in alcohol particularly, because often the cytochrome enzymes can become saturated with alcohol. Small doses can lead to a large increase in plasma concentration, and you can quickly get out of that therapeutic window into a toxic zone, and it's difficult to stay within the therapeutic window. First order we've been through, where we're dosing it. This is the same drug being dosed in different frequencies. Zero order is when these metabolizing enzymes have been saturated. that's a pretty hard lecture. So best of luck with it. Let us know if you have any questions. I remember I asked faculty a lot of questions about that lecture because I didn't understand it and I was really annoyed. So you're welcome to be as well. Microbiology, we're starting with bacterial pathogenesis. These lectures were a bit unusual in which they gave a lot of examples that you don't really need to know. They come back later. So we're just going to go through the core concepts. This says, I made this table at the start of the year and I think it's really pretty, so I put it in here. But it's essentially an overview of the innate defenses of the immune system. It's not relevant. Oh, normal flora is relevant. So as you remember, normal flora is commensal and mutual relationships between humans and bacteria. They limit growth and attenuate pathology by competing for nutrients with bacteria, by occupying space physically and producing inhibitory substances such as free fatty acids. There's an infectious cycle of disease. This is in almost every lecture, which kind of shows that a disease in order for pathology to occur, it needs to be transmitted, it needs to enter a body or colonize it, overcome host defenses, growth and spread and damage hosts. This is just showing you how the pathogen can enter and how it can exit and become infectious. So they want to emphasize that not all bacteria is bad. Some bacteria has beneficial commensal functions with humans, such as normal flora that are involved in our ability to digest and retain vitamins and nutrients, as well as outcompeting with pathogens. Pathogens, however, are particular bacteria that have criteria. They survive and replicate by gaining nutrients from the host, so they're like parasitic. They take up space and our nutrients for our cells to thrive. They can cause damage to normally sterile sites, plus as blood, organs, and CSF. Commonly asked questions are, what are the sterile sites? So you should learn those. And these can damage either directly, physically colonizing, or by secreting toxins into these spaces. And the reason why there is disease is because the interaction between a pathogen and a host may perturb homeostasis. In other words, it may bring the body's state away from homeostasis, resulting in disease. For example, the pathogen might take all our nutrients, so our cells are starving. A pathogen is an organism capable of causing disease, either directly through toxins or indirectly by triggering an overactive immune system that ultimately causes immunopathology and harm to our cells. Pathogenesis is a process where organisms cause disease. Virulence is a measure of the ability of an organism to cause disease. For example, a very virulent pathogen causes lots of damage and is very damaging. Virulence factors are the little factors or little proteins or little mechanisms used by these pathogens to cause disease. That's not how you spell cause. I'll fix that later. Potential. I'm probably going to forget. Okay. To cause. Spoilers. So these are examples. There's a ton of virulence factors, and they have an image where she goes through each one in the lecture. It's just not that high yield, so I focused on the high yield ones, which are particularly the adhesive ones. And these are involved in the colonization of host tissue and mucosal surfaces and can often make or sometimes make biofilms that can't be penetrated either by antibiotics and is very difficult for our immune system to penetrate because they've made a layer of dense pathology. Some adhesive virulent factors are fimbriae or pili. Pili are involved in sex conjugation. Fimbriae are more involved in the adhesion. These are involved in you can see these in gonorrhea. They kind of can stick to surfaces in the lungs. They can stick to surfaces outside physically as fomites, and they are adhesive. Glycocalyx is a sticky polysaccharide capsule that is primarily involved in creating biofilms and is also involved in the evasion of the immune system because the immune system can't interact with those antigens because it's blocked by this polysaccharide layer. Hi, I'm just giving a lecture. It's all good. You can come in if you want. Afimbrial adhesions. These are surface proteins. I have a picture of them in the next slide. Bacteria will coat themselves in the host extracellular components, and particularly in fibronectin and other complexes, and this allows it to stick. I have a picture over here. You can see it's covered itself in host extracellular glycoproteins, and in order for it to be adhesive. Afimbrial adhesions, not very high yield. Pili and fimbriae, very high yield. Pili primarily sex conjugation, fimbriae primarily normal adhesion. Remember, sex conjugation is when they share plasmids between the bacteria. You can transfer antibiotic resistance that way. This is a picture of some pili. they go to they kind of latch onto the glycoproteins of a host membrane cell, and that's how it adheres. They can also adhere to each other, and they can also adhere to surfaces. Important to remember, a pathogen can have all three of these. It can have a capsule, pili, and afimbrial, and fimbriae. Yep. The adhesions. I think I went over that. Can adhere to surfaces to teeth, particularly can have biofilms in your teeth. That makes plaque build up, and you can destroy your teeth that way, and they can stick to each other. The adhesions, the fimbriae, pili, afimbrial, and capsules allow bacteria to form biofilms which can evade immune systems and render biotics ineffective, particularly difficult to penetrate and destroy. If they're going to ask you a question about adhesions, they're probably going to say they can form biofilms because these are quite clinically relevant and hard to treat. In summary of all of this, a pathogen will breach host natural barriers, which I put my little tables on at the start. Once inside the body, the pathogens can cause adhesions and begin a mass colonization, which are hard for the body to target and treat. And then the pathogen can disseminate throughout the body, invading. These are ways the cells can invade and evade. Invade and evade. Toxins can be cell killing. They can kill neurons, and they can stimulate immune simulations. For example, they can create a cytokine storm, which overacts the immune system and lead to septic shock, which is a very dangerous situation, and we'll discuss later. The immune overactivity will cause damage through immunopathology. You can evade through resistant phagocytosis and detection, or invade and colonize cells that are not accessed by antibodies or cannot be accessed directly. Then they give you a couple of examples of invasion and evasion, and they might ask you one question about all of these, but it's kind of cool. Like, this is what you retain. So this is one example of how invasion occurs with bacteria. What it will do is it will kind of release these enzymes called hyaluronidase, and these are involved in degrading the extracellular matrix. As well as that, hyaluronic acid maintains the integrity of an epithelial layer. So the hyaluronidase is going to degrade that hyaluronic acid, destroying these epithelial cells' connections. Perhaps these are tight junctions, and it's going to spread through there. Then you're going to have a basement membrane sort of thing, a kind of collagenous material at the bottom, separating it from the tissue, from the extracellular fluid. Collagenase degrades collagen in extracellular matrix. And once this barrier is breached, the microbes are through. They essentially can disseminate everywhere. Another way of, so that is invasion. Now we're going to talk about evasion, is a way in which bacteria can form clots. And then once a latency period occurs, after a particular time is right, then they're going to release the clot and they're going to go into the bloodstream. So coagulase is involved in forming clots. Streptokinase dissolves clots. For an exam, if you just remember coagulase forms clots, streptokinase dissolves clots, you'll be pretty all right. You'll probably get this question right without actually understanding it. But what happens is coagulase will convert fibrinogen into fibrin, forming a solid clot. And when the time is right, it's going to release streptokinase, which dissolves the clot and allows it to break. Streptokinase is also used clinically to dissolve clots, so maybe that will help you remember it. H. pylori is an important pathogen, probably the most important pathogen that we've learned about. I feel like they talk about it the most. After Staph aureus. Any question on microbiology, if you're not sure, circle Staph aureus. And then the next most important one I'd say is H. pylori, because they talk about it all the time. So H. pylori contains enzymes that can neutralize stomach acid. They contain a urease enzyme, which reduces pH by cleaving uric acid and producing ammonia. You can see here, the urease is producing ammonia and carbon dioxide. The reduced pH decreases the mucosal cell viability, making mucin. Mucin is important gas cell, a gel that's in your stomach that protects the stomach. And when you get rid of the mucosal cell viability by reducing pH, you can often make this become liquefy. And as a result, H. pylori can swim through and cause debilitating ulcers. So here's a diagram where you can see this mucin in the stomach acid is protecting the epithelial cells below, because you can imagine stomach acid is a very hostile environment, has a very low pH. And H. pylori will release urease, which will neutralize the stomach acid, liquefy mucins, so the bacteria can swim through. Yeah, thanks. Yeah, catch out, right? Comes up a lot. Enzymes degrade immune components. So these are some enzymes that are involved in pathogenesis. Again, very low yield. I remember one question on it though. IgA proteases cleave secretory IgA in mucosa. IgA is a secretory antibody in often lining mucosa, and IgA proteases cleaves that, so they're not effective in their antibacterial action. A DNase allows escape from neutrophil extracellular traps. These are new, like they're quite recently discovered, so they talk about them a lot in first year. A neutrophil will explode itself when it feels overwhelmed by pathogens, and that will leak viscous DNA that will trap pathogens and lytic enzymes that will break them down. So whatever is stuck gets killed. So some bacteria contain DNase that can break this down. And there are also enzymes that degrade the complement interaction, which we went through last time. Mimicry is when you can either have a pathogen bind host molecules on its surface, and so the immune system isn't triggered by it, it just recognizes it as a self-cell, leaves it alone. Or a capsule can mimic polysaccharides that are local to the host and disguise the pathogen, or it can literally, the polysaccharide coat can just mean that defense enzymes can't get to the protein that stimulates the normal anti-pathogen response. So the capsules are used for mimicry as well, to mimic the body, as well as binding host molecules and surfaces. Staph aureus does this. Now the second part of this lecture, bacteria cause host damage through two primary mechanisms. They release endotoxin and exotoxin. I did this very late at night, as you can tell. And exotoxin. And these will stimulate a lot of immune pathology. So these are going to trigger a lot of cytokines being released, lots of vasodilation, lots of inflammation. You're losing a lot of blood from your circulation. You're getting hypertension. You're underperfusing your organs, and you can have serious consequences. Endotoxin is worse than exotoxin. Remember that? Endotoxin, red flag, really, really bad. Endotoxin is exclusively in gram-negative bacteria, as it is made from an active component called lipid A, which exists in the outer membrane of the lipopolysaccharide. As you can remember, in gram-negative, you have these lipopolysaccharides. In the gram-positive, they're not as significant, and it's this lipid A that causes the toxic component. Remember, lipid A causes toxic component. It can cause septic shock, activating immune mechanisms. Endotoxins are much worse than exotoxins, which is why gram-negatives are generally more dangerous than gram-positive, generally. It's a general rule. Exotoxins are proteins that are usually secreted, and they have a variety of effects. You can see endotoxins being excreted there. Exotoxins being excreted here, destroying the cell. And what's interesting is often the way that these endotoxins are released is when the pathogen is destroyed, because that's when the membrane kind of flies off everywhere. So you have to be careful when treating gram-negative bacteria, for example, in sterile environments, because then you're going to release a lot of endotoxin. So sometimes bacteriostatic is the best therapy, or sometimes it's so serious that you have to take the consequences of the serious immunopathology and just get rid of that bacteria as quickly as you can. This is the main point of her lecture, is her emphasis of septic shock. Endotoxin can lead to septic shock. Causes are often gram-negative systemic infections, and there are indirect effects. They're caused by indirect effects mediated by host molecules that lead to a cytokine storm, releasing TNF-alpha and interleukin-1, as well as clotting activation. So you have a lot of clotting going on, a lot of vasodilation, a lot of swelling, and as a result, you're going to have fever, shock, coagulation, weakness, inflammation, intestinal hemorrhage. It's a really significant medical emergency that requires quick treatment. Endotoxic septic shock is different to the word sepsis. Sepsis is just the body's extreme response to an infection and is not synonymous with endotoxic shock. And the primarily reason why this is important is non-gram-negative pathogens can cause sepsis. So fungi can cause sepsis, which is just an extreme response to an infection. This is the mechanism of the LPS leading to shock. All I would remember is LPS can lead to hypertension and coagulation and fever. I hope it makes sense why it causes hypertension. Is the fluid leaks out of the blood vessels and you have underperfusion of the organs. Sepsis is a systemic inflammatory response created in response to pathogenic infection. Hypertension is low blood pressure and can fall to a point where the blood does not reach the brain, causing dizziness and fainting, and it can also lead to death. Septic shock is a sepsis-induced hypertension that persists despite adequate fluid treatment. So think of it like loss of fluid that occurs in a fluid response. You get that swelling. Despite all the fluid you're pumping back into the system, that's continuously put out into the tissue. It goes out of the vascular system into the tissues because you're in this constant state of inflammation. Sepsis can cause multiple organ failure, including death. There's a couple of classes of exotoxins. The main one are superantigens, and the only reason why you really need to know this is sometimes they ask about Staph aureus superantigens on exams because they were historically associated with tampon use. That's why people say to change tampons and not leave them in, because there was a kind of a health crisis where women would leave tampons in, Staph aureus would colonize it, and that would lead to a massive cytokine release, leading to a form of shock as well. My computer's, I'm just going to charge it. Give me a second. Was a massive cytokine release. Toxins, and that's also kind of how COVID, one of the reasons COVID was really damaging is it led to a massive cytokine release, leading to a lot of immunopathology. Toxins that act at cell surfaces are a different type of class. These can punch holes in cell membranes or destroy lipid bilayers. And the final type is toxins that modify intracellular targets, which is sometimes asked on exams, and we'll go through. These are diagrams showing the tampon use of vaginal colonization by S. aureus. Exotoxins were produced and led to sepsis and lots of inflammation and cytokine storm, and it was really damaging and quite dangerous and deadly. So you can see there's this super antigen that hyperactivates the T cells when it comes in contact with the antigen presenting cell. And that's why you have such a huge cytokine release. Two types of toxins that target cell surface. We're almost done. Stay with us. Phospholipases lead to the hydrolysis of the membrane phospholipids. And an example is Clostridium perfringens alpha toxin. I was hesitant on whether to put examples in because you don't really need to know them. So the slide was just bare, so I put it in, but you don't really need to know that. The other type of pore forming, you can remember some of the complements led to a membrane attack complex, which put pores in phospholipids, C5, 6, 7, 8, 9. And Staph aureus alpha hemolysin is a pore forming. If in doubt, Staph aureus, because it does almost most of these, it does a lot. C. perfringens and alpha toxin. I put C. perfringens in because it's a significant role in gas gangrene, which is quite examinable because it's a medical emergency. Has phospholipase C activity, and it works by creating an anaerobic environment and is very dangerous and deadly. It causes a lot of cell lysis and death. You need to amputate gangrenous limbs. This is high yield. I don't know why it was, but this was on a couple of questions and quizzes, and you saw it around. Intracellular target modifying. These are the most common type of bacterial toxin, and they have two components, an A component and a B component. The A component is responsible for the enzymatic activity that modifies the intracellular target. The B component is involved in the binding of a toxin to cell membrane and translocation of A component into the cell. So B is used to help A. So you can imagine A is better, so B assists A. Its life goal is to make A get into to activate A, to assist it. So the B subunit is going to bind on the membrane. It's going to allow A to enter the cell, and then A's are going to go around and do its enzymatic activity. Two types. This diagram shows a simple AB toxin, known in diphtheria. Compound AB toxins include cholera toxin AB5. This cholera toxin AB5, being a compound AB toxin, was high. It was on quizzes. I have no idea why, but it was. So for your information. How much time do we have left? I hope that was helpful. 12:22, we start at 11:30. It's almost an hour. How are we feeling? Can we do?
No, I think we'll skip this for this week. Yeah, but I just wanted to let you guys know that the upper limb slides are up on the Google Drive, and at the end of the slides, I've organized this where I put some questions in. So there'll be some questions that we've done before, and I've included some 2016 mid-sem questions. So have a look at that. if you don't want to look at exam questions before, then don't look at it. I did indicate which ones were exam questions. So if you guys want to look at it, don't look at it. If you guys do want to have some practice, then go for it. Yeah, and sorry for the inconvenience. I thought you guys had 3 weeks of anatomy lectures, which is how we did it last year, but I think they changed it to just 2 and like put everything in there, and then you guys do it over and over again during tutorials. But hopefully everything's covered in the slides. If you guys have any questions or feel like anything's missing, let me know. Otherwise, that's all for today, guys.
Well, are there any questions from today's slides?